All right, so today we'll start our discussion of airways, and we'll start by talking a little bit about bronchiectasis. So what bronchiectasis represents is abnormal dilatation of the airways. So it's localized irreversible dilatation of the bronchial tree. And in most cases, bronchiectasis is caused by infection. And so what we can have is this vicious cycle of bronchiectasis, where you will have infection, and the infection damages the lining of the respiratory tract. It also affects the mucociliary clearance. So that damage can result in some dilatation of the airways, but also results in the airways being susceptible to recurrent infection, and then those recurrent infections damage the airways even more. So bronchiectasis can beget bronchiectasis, and you get into this vicious cycle where bronchiectasis can get worse from recurrent infections. So if somebody has bronchiectasis, infection is one of the things that we think about. We also think about causes for recurrent infections. For description of bronchiectasis, there is an anatomical description that we use based on the appearance of the airways. So your three basic types going from left to right. What are these types of bronchiectasis? The mildest form is called
cylindrical.
Then we have
varicose,
and then you have
cystic.
Right. And those are purely descriptive terms. So cylindrical term is the mildest form of bronchiectasis. You can have thick-walled bronchi. The number of bronchial subdivisions is usually still normal, meaning that the distal airways are not obliterated by fibrosis. You have varicose bronchiectasis. This is a little bit worse, so you can see the irregular beating of the airways. Here, the more distal subdivisions are affected, so you can have bronchiolitis obliterans in the more distal airways. And then the most severe form is cystic bronchiectasis, where you have ballooned airways. And here, of course, the bronchial subdivisions are further reduced. And what can happen here when you develop cystic bronchiectasis is that you can actually develop infection within these cystic areas of bronchiectasis themselves. So you can see these air fluid levels within the areas of cystic bronchiectasis. Okay. So these are just descriptive in terms of the anatomic appearance of the varieties of bronchiectasis. There's one other kind of bronchiectasis which is illustrated here. So what's illustrated here?
Traction.
Yeah, so this is traction bronchiectasis or bronchiectasis from scarring cicatrization bronchiectasis. In this particular case, what do you think the cause might be?
Chronic aspiration.
It's in the wrong place though for that, right? Chronic aspiration is lower lobes. Tuberculosis, yeah. Tuberculosis is a common cause. There's volume loss too up here. So tuberculosis is a common cause of atelectasis, bronchiectasis, and fibrosis, especially within the right upper lobe. You can see the airways on the other side. There's some parabronchial thickening there too, so those are abnormal too. So traction bronchiectasis or cicatrization bronchiectasis. This is bronchiectasis from scarring. Okay. So here you have an example of sarcoid where we can see there's fibrosis in the upper lobes resulting in traction bronchiectasis. This is a patient with NSIT, and you can see the traction bronchiectasis here within the lower lobes. And if you want to look at the airways, then there are these particular reconstructions that we can do that nicely illustrates the airways for you. What have we done here?
Minute.
Yeah, so these are MINIPs. So MIPS you're used to looking at, that's what you look at for angiography work. So with MIPS, maximum intensity projection, there you're looking at the highest attenuation pixel within your volume. Here you're looking at the lowest attenuation. So these are good for looking at airway structures like airways, emphysema, emboli. So if you want to look at the airways, you can do MINIPS to look at the airways. So we'll talk about some diseases and causes of bronchiectasis. So for this particular case, what are the findings that we have here? Well, given the topic of the lecture, the first thing you want to point out is what? Bronchiectasis, yes, where?
Left upper lobe bronchiectasis.
Yes, we have bronchiectasis here in the left upper lobe. What else do we have?
Central lobular opacity in the left upper lobe.
Yeah, so you have these central lobular opacities here, right? And then what else can we say about the left upper lobe?
something cystic.
What?
Left upper lobe. Cystic space in the left upper lobe.
Yeah, so there's that cystic area there. Is there architectural distortion? Well, is there loss of volume in the left upper lobe?
Yeah, there is.
How do you know? Well, what is it that you see here? What is this?
Is that out of like this?
Well, yeah, but what am I pointing to? That's the major fissure. Notice you can see the major fissure here on the left side. You don't see it on the right side. So why do we see it there?
Pulled upwards.
Yeah, the left upper lobe is retracted upwards, so there's volume loss in the left upper lobe, right? There's architectural distortion. You can kind of see it here too, as the airway is retracted upwards immediately, right? So then here's the fissure is distorted. So you have here some scarring, fibrotic change in the left upper lobe, central lobular opacities, bronchiectasis. What do you think the cause of the bronchiectasis is in this patient?
TB.
Yeah, this was a case of tuberculosis, resulting in scarring and these central lobular nodules, somewhat tree and bud here, right, from tuberculosis in this particular patient. This is a 21-year-old woman with tuberculosis. So tuberculosis, as we know, tends to give us upper lung disease. Here's a nice case of a 56-year-old man with TB, these fibrocavitary changes within the upper lungs. And many times what we see as these cystic areas that look like cavities on CT, on chest radiograph, many times those areas represent areas of bronchiectasis. You can see honeycombing here, and the honeycombing results from the airways being distorted. So these cavitary areas many times actually communicate with the airways, right? So tuberculosis is a very common cause of bronchiectasis within the upper lobes. And you'll see other findings too, like the central lobular opacities from the bronchiolitis associated with TB. So these tree and bud opacities, you have cavitary lesions like this with tree and bud, so we think of infections. TB, atypical mycobacteria is a very common cause of this appearance. What about this case? What do we have here?
Bronchiectasis in the right middle lobe and left lingula.
Yeah, so here you have bronchiectasis in the right middle lobe and lingula, and then whenever you, also some fainter central lobular opacities there, and whenever you see disease in that distribution, what are you supposed to think about?
Lady Windermere.
Yeah, so Lady-Windermere syndrome, atypical mycobacterial infection, right? So that affects the right middle lobe and lingula preferentially. So if you have bronchiectasis in those areas preferentially, that's what we want to think about. Chronic aspiration, this is also a very common cause of bronchiectasis. This tends to affect the lower lobes. So if you see bronchiolitis within the lower lobes, parabronchial thickening, bronchiectasis, you want to think about chronic aspiration. That can do that. Right middle lobe syndrome, this is when you have recurrent atelectasis and bronchiectasis in the right middle lobe. This can occur because the right middle lobe bronchus is very easy to obstruct when you have right hilar adenopathy. So anything that enlarges nodes in the right hilum can impinge on the right middle lobe bronchus. And then that makes atelectasis and the susceptibility to infection increased in the right middle lobe. So here there's right middle lobe atelectasis, and you can also develop recurrent pneumonias and bronchiectasis there. And it's very easy to obstruct the right middle lobe bronchus if you have right hilar lymphadenopathy. Endobronchial tumor like carcinoid, so this can expand the airway. So this can obstruct the airway centrally. You can develop mucoid impaction distal to that. You can get expansion of the airway. So a central obstructing tumor is another cause of bronchiectasis. But here you think of slow-growing tumors to allow time for the bronchiectasis to develop. But carcinoid as a central obstructing tumor can result in bronchiectasis. What do we see here on the chest radiograph?
Finger and glove sign.
Yeah, so here you have the finger and glove sign, okay? So what is the significance of the finger and glove sign? What does it mean? What causes that finger and glove sign? So that's caused by mucoid impaction, right? So if you have a focal area of mucoid impaction, as in this case, what are causes of focal mucoid impaction?
ABBA.
So ABPA, allergic bronchopulmonary aspergillosis, can do that, so you'd want to know if the patient has what?
Asthma.
Asthma. What's another cause of focal mucoid impaction? How's your short-term memory? Just before this, we discussed tumor, slow-growing central tumor like carcinoid can do that, okay? What's a congenital cause of a focal area of mucoid impaction? Congenital bronchial atresia, right, especially in the upper lobe. So that can also give you a focal area of mucoid impaction. This is an interesting looking CT. What do we have here?
This is ABPA.
Why?
Looks like high attenuation mucus within the.
Yeah, so looking at these things, you might first think, well, these are blood vessels, right? But how do you know they're not blood vessels?
It's not contrast.
What?
It's not contrast.
It's a non-contrast CT, right? So what else besides blood vessels can be tubular and branches in the lung? Well, those can be airways. It's a non-contrast CT, but these airways are filled with high attenuation material. So high attenuation mucoid impaction, that can be a characteristic of allergic bronchopulmonary aspergillosis, right? So this turns out to be an asthmatic with allergic bronchopulmonary aspergillosis, giving you high attenuation mucoid impaction, a rather dramatic example of that. So ABPA, we've discussed this before. So this is secondary to infection with aspergillosis. It damages the airways. Asthmatics are susceptible to this. And if you have an asthmatic with bronchiectasis and mucoid impaction, especially if it's high attenuation mucoid impaction, you can think about allergic bronchopulmonary aspergillosis. So it can give you the finger and glove sign, as in this case. Other things you might see, atelectasis, consolidations as a result of the airway obstruction, the mucoid impaction, finger and glove sign, and then the bronchiectasis. And so if we have an asthmatic with bronchiectasis and mucoid impaction and allergic bronchopulmonary aspergillosis, is something that you want to consider, something that you should bring up. It's said that classically ABPA gives you central perihilar bronchiectasis, but in reality the bronchiectasis can be in any distribution in patients with allergic bronchopulmonary aspergillosis. And we also talked about high attenuation, even on non-contrast CT. If you notice high attenuation mucoid impaction, that can also be a feature of ABPA. And it's a result of the metallic ions that are associated with the fungal infection. So that results in a high attenuation mucoid impaction. Which is also why, by the way, you get susceptibility artifact, right? In neuroimaging, when you have sinusitis as a result of fungal infection, aspergillosis, because of the metallic ions associated with the infection. That can also lead to this susceptibility artifact on MR. That can help you diagnose the disease when you're sitting in the neuro section, okay? This is a 15-year-old woman. What are the findings on the chest radiogram? Is that a normal chest X-ray? No. So what would you say is abnormal? How would you describe the abnormalities here?
Like reticular opacities.
Yeah. So the word you'd like to use here is reticular opacities. Yeah. And the distribution of those opacities?
More in the upper lobes.
More in the upper lobes, right. So you have these abnormal reticular opacities. You might also wonder if some nodular opacities, but mostly reticular opacities in an upper lobe distribution, right? So what could do this?
Like sarcoid.
Yes, so sarcoid might be something to think about, right? So that can give you reticular opacities in an upper lobe distribution. So 15-year-old is young for sarcoid, right, to do this. If we look carefully at these opacities, right, what do we notice here? Notice that there are two of them close to each other, right? And you also, when you look at the airways, right, what do you notice about the airways?
Dilated.
Thickened.
There's parabronchial thickening, maybe a little dilatation of the airways. So this is called a tram tracking sign, right? So that tram tracking sign is a sign that you're looking at an airway here, okay? So we have parabronchial thickening like this, upper lobe distribution, reticular opacities in a young woman. what might we consider?
Fibrosis.
Yeah, so if you have airway disease, especially bronchiectasis, upper lobe distribution in young patients, you want to think about cystic fibrosis. And it's always surprising how the CT always looks so much worse than the chest radiograph, right, in a lot of these cases. So you have here the bronchiectasis, parabronchial disease, all of these kind of tree and bud nodular opacities from bronchiolitis. So cystic fibrosis in young patients is a common cause of bronchiectasis. So we all know about it, autosomal recessive, dysfunction of exocrine glands, viscous, tenacious secretions, recurrent infections, especially Pseudomonas, results in the airway damage and the bronchiectasis. Tends to be upper lung predominant. What they say is that because the secretions are cleared easier and coughed up from the lower lungs, that they tend to hang around more in the upper lungs, and that makes the damage, the airway damage, tend to be more severe within the upper lung distribution. So with cystic fibrosis, you'll have increased lung volumes because of air trapping. You can have enlarged hilar shadows because of adenopathy if it's related to infections. In later stage, you can develop pulmonary hypertension. That can give you big pulmonary arteries. And then bronchiectasis, predominantly upper lung distribution. And you can also have mucoid impaction. Complications, in addition to pneumothorax, hemoptysis is also a complication. Any chronic infection, inflammation can cause hypervascularity within the lungs. You get hypertrophy of the bronchial arteries. And remember that the bronchial arteries are under systemic pressure. So with hypertrophy of the bronchial arteries, that can lead to bleeding. And the bleeding, because it's under its arterial pressure, can be pretty severe, might require embolization. So that is also a complication of cystic fibrosis. So if we have a young patient with increased lung volumes and very dirty looking lungs, mid to upper lung distribution, that's a clue that you might be dealing with a case of cystic fibrosis. You can see the increased lung volumes, the flattened diaphragms, and then here on the lateral view, you can really see these areas of bronchiectasis. So bronchiectasis in a young person, you want to think about cystic fibrosis. And then here on the CT, it's pretty easy. You can see these areas of bronchiectasis here. What is this nodule? It's a mucous impaction, right. And so when that's coughed up, you're going to be left with these areas of bronchiectasis. Okay. Interesting CT. What do we have to say about this? What's abnormal on the CT scan? Well, first, what about the airways? What do we notice about the airways here? There's bronchial wall thickening, right? There is some dilatation. There is bronchiectasis. What are all these nodules? What's the distribution of the nodules?
Central lobular.
Surprise, it's central lobular. We're dealing with the airway disease, right? So that represents bronchiolitis. So we have somebody with airway disease, parabronchial thickening, some bronchiectasis and bronchiolitis, right? So what could this be? What are some thoughts that you have? Even diseases that we've covered already, what could it be? Could it be chronic aspiration? Could be, it's lower lung distribution, right? That could do it. Atypical mycobacterial infection, TB, right? Even though it's a lower lung distribution. You're pointing to something.
Yeah, the heart.
What about the heart?
Rotated to the right.
So what does the patient have?
Cardiac syndrome.
Yeah, so so the patient has dextrocardia, okay? So bronchiectasis associated with dextrocardia, you said Cartaginer syndrome, yeah. So what is Cartaginer syndrome? What's the triad for Cartaginer syndrome? Well, first of all, it's under the subheading of what?
Yeah, ciliary dyskinesia.
Ciliary dyskinesia or motocilia syndrome, right? The triad for Cartaginers is?
So sinusitis.
Sinusitis.
Situs inversus.
Situs inversus.
And
well, what you're looking at here, bronchiectasis, right. So these patients develop recurrent infections because of their motocilia, right? So they're susceptible to recurrent infections. And so they'll develop bronchiectasis and then sinusitis and everything else. So what percentage of patients with a motocilious syndrome have cartilaginous?
50%.
50%. That's an interesting number. So why is it that 50% of patients with a motocilia have situs inversus? You can either have it or not have it, that's 50%. Okay, I guess. Well, it's thought that ciliary function is necessary during embryogenesis to get proper cell migration to have normal situs. And when you don't have that, situs becomes random. So it's interesting that in patients with immotocilia, 50% will have situs inversus and 50% will have normal situs. Those who have situs inversus, we call that cartilaginous syndrome. Okay. So bronchiectasis, situs inversus, sinusitis, this is the triad for cartilaginous syndrome. Right? So it comes under the heading of ciliary dyskinesia, motocilia syndrome, impaired mucociliary clearance, recurrent infections. That's what we see. Now, you can have patients who don't have situs inversus, right? So this is also something to consider. You have a patient who has recurrent infections, bronchiectasis. This tends to give you the bronchiectasis that's more severe in the lower lung distribution, right? So ciliary dyskinesia or motocilia syndrome, think about this in patients who have bronchiectasis, recurrent infections, lower lung distribution. Again, they don't have to have situs inversus, right? If they have situs inversus, it's easy, but they don't have to have situs inversus. So you can bring this up. Here's a patient who had motocilia syndrome who doesn't have situs inversus and bronchiectasis here in a lower lung distribution from recurrent infections, okay? So that's cartilaginous syndrome. Easy on the chest radiograph, right? You have dextrocardia, although the most common cause of dextrocardia on a chest radiograph is mislabeled chest radiograph. Yeah. I mean, there's a famous story about a clinician who calls a department and says, what's wrong with you guys? I sent this patient to you for a chest x-ray 5 times, and every time you tell me the chest x-ray is normal. You go, what do you mean? And he goes, well, the patient has situs inversus. Okay, so every time they assume that the x-ray was mislabeled, they just read it as normal. Okay. Now, there are any chronic immunodeficiency. This is a patient with secretory IgA deficiency, like Shinya Kagashi. I mean, the list goes on forever. But any chronic immunodeficiency can also result in recurrent infections, and that can cause bronchiectasis in the lower lung distribution. So also in your differential for bronchiectasis in somebody who's having recurrent infections, underlying immunodeficiency, motocilia syndrome, chronic aspiration, these are the things that you might consider. Okay? So again, the tram tracking here in the lower lung from bronchiectasis in this particular patient, and you can see the bronchiectasis lower lung distribution from recurrent infections in this patient. What's abnormal here on this chest radiograph?
Dilated trachea.
Yeah, so the trachea is dilated. So you can see the trachea is dilated there on the frontal view, and it's also dilated there on the lateral view. Okay, so what do we think about when we see here? When we see this? So this is called Meunier-Kuhn syndrome or congenital tracheobronchomegaly. Another nice characteristic of Meunier-Kuhn is also demonstrated on the lateral view. What is it? Besides the dilated trachea, you also see what?
There's probably ridges.
This corrugated appearance is also very typical as you get prolapse of the mucosa through the cartilaginous ring. So that corrugated appearance of the trachea is also very typical for Meunier-Kuhn syndrome or congenital tracheobronchomegaly, right? Another feature of this is that surprisingly most patients are male. So you'll have this corrugated appearance of the trachea, and also extends to the mainstem bronchi. So you have dilatation down to the mainstem bronchi with Meunier-Kuhn syndrome. So diffuse dilatation of the trachea and bronchi, 95% of patients are male. This also predisposes these patients to recurrent pneumonias, and it can be associated with connective tissue disorders I've listed there. Okay, So this Marfan's can also be associated with Muir-Kuhn syndrome. So the dilated trachea, dilated central main stem bronchi. For numbers, tracheal coronal diameter greater than 26 in men and 23 millimeters in women. Dilated trachea here, that corrugated appearance of the trachea in the airways is also a typical feature of Muir-Kuhn syndrome. And here's a nice volume rendered view showing you the trachea and the central airways in that patient. Okay. What's abnormal here on this chest X-ray? So you see these cystic areas, right? See those cystic areas in the lower lobes. Now, again, given the topic of the lecture, you know what to think about, but it's not obvious that this is bronchiectasis, right? But there is a feature of it, though, that should make you think about bronchiectasis here. And what is it? The air fluid levels, yeah. So you have these cystic areas within the lower lung distribution, but they also have these air fluid levels in them. So this is somebody with severe cystic bronchiectasis, okay, with these air fluid levels. That's what it looks like on CT. So you have these areas of cystic bronchiectasis with air fluid levels. Rare congenital disease of airways associated with cystic bronchiectasis. Williams-Campbell, right. So that can cause widespread cystic bronchiectasis. It's a deficiency here within the bronchial walls, partial absence of cartilage. And so this affects the more distal airways as opposed to Muir-Kuhn, which is dilatation of the trachea in the more proximal airways. So these patients also are prone to recurrent infections. They will develop cystic bronchiectasis. So cystic bronchiectasis here, this one has air fluid levels because of the infection. So that is Williams-Campbell syndrome. All right, let's move on to tracheal bronchial abnormalities here. Now, when we look at the chest radiograph, what's abnormal on the chest radiograph?
Right paratracheal opacity.
That's right. There's a right paratracheal opacity. So that's the abnormality here on the chest radiograph, which is why the patient got a CT. So just looking at the chest radiograph, what's the first thing you might think about that would cause that? Lymphadenopathy, yeah. So lymphadenopathy, right paratracheal lymphadenopathy should be the first thing that you might consider. That would give you an opacity like that. When we look at the CT, though, what do we have here?
Atelectasis next to the trachea.
So right next to the trachea, there's this round opacity, right? And you think it's atelectasis. Why do you say that? What do you think is causing that?
The bottom image looks like there's like air spaces inside of it.
Looks like there are air bronchograms in there, right? So what's the cause of this? What's happening in this patient then?
Outpouching in the trachea to the right.
So what do we call this?
Tracheal bronchus.
Yeah, so this is a patient with a tracheal bronchus. So this abnormal bronchus from the trachea going to this area of the lung, and a complication of tracheal bronchus is, well, it's illustrated here. What is it? Atelectasis, yeah. These are easily obstructed. So think about it, if this patient received an endotracheal tube, right? So these are easily obstructed. So atelectasis, pneumonias within the area of the lung that is supplied by the tracheal bronchus can be a complication of this, okay? So that's a tracheal bronchus. It tends to come off the trachea, supply the apical segment of the right upper lobe, all right? Sometimes it can replace the apical segmental bronchus. Notice this one is missing. There's no apical segmental bronchus in this patient. Or it can be an accessory bronchus. It can be an additional bronchus supplying the apical segment of the right upper lobe. Here's a bronchogram showing you that tracheal bronchus going to the right upper lobe in that particular patient. So also called pig bronchus, although pigs don't really have this, but bronchus coming from the trachea to the right upper lobe, medial or apical right upper lobe is tracheal bronchus. Most cases asymptomatic, but can result in obstruction and atelectasis. Okay. What do we have here in this case? So if we look at the airways there in the right lower lobe,
Trachea off to the heart.
There's an accessory bronchus coming out the bronchus.
so there's this bronchus here that goes medially towards the heart, but the thing about it is that it's blind ending. It doesn't go anywhere. It just kind of goes there and stops, right? So what is that called? That's called a cardiac bronchus, right? So it's a blind ending bronchus that can come off the bronchus intermedius or the right lower lobe bronchus, goes towards the heart and then just stops. That's called a cardiac bronchus. These are pretty rare, but if you remember to look at your airways, and the same thing, trachea, these things are easily missed. Tracheal bronchus especially, because it's so easy to scroll through the images and not pay attention. But if you purposefully, every time you look at a chest CT, scroll through and look at the airways, and then you'll pick up lesions within the airways. You'll also pick up abnormalities of the branching patterns. Okay, so make sure that you add that to your checklist as you look at chest CT scans, to make a conscious effort to scroll through and just look at the airways. So that is a cardiac bronchus, usually blind ending. Pretty unusual. Okay. So this patient was involved in a motor vehicle accident. The trauma surgeon comes over to you and says, I think it's a pneumomediastinum here. I want to do an esophagram, a CT esophagram. What are you going to say?
So it's a tear.
What?
There's like a tear in the bronchus or the trachea.
So is that an injury?
Yes.
So you'd say that that's a traumatic injury to the trachea, tracheal laceration. Do we agree?
It could be a tracheal diverticulum.
Yeah, so this is a tracheal diverticulum, or also called paratracheal air cyst. Okay, this guy over here is what?
Esophagus.
That's the esophagus. Here's the trachea. That's the esophagus. In most cases, you don't actually demonstrate the communication with the trachea. In this case, we happen to see it, but in most cases, you don't. These are very common if you remember to look for it. So a lot of times, there are these normal things on CT that you never notice because they're inconsequential, right? They're not part of pathology. And then somebody points it out to you and you realize you don't know what it is, right? But if you, now as you go through your chest CT scans, look at the inlet, look at the tracheal inlet, look at the inlet, the thoracic inlet. These are very common. You will see these very commonly, and they're always in this location. So it's thought that the position of the esophagus here prevents these from occurring on the other side. So you'll always see them on the right side at the tracheal inlet here, kind of along the tracheoesophageal groove. It's a paratracheal air cyst. These are pretty normal, inconsequential, mean nothing except that you want to recognize it as a normal finding so that you don't misinterpret this as pathology. Okay? And then in this particular case, we're actually able to see the communication with the trachea, although in most cases you don't demonstrate that when you're looking at it on CT. And then you can have stuff in here. You can have a little mucus in here, some mucus strands in there, so you will see that also on CT. So it's a paratracheal air cyst. What do we have here?
Mass going into the trachea.
Yeah, so here there's a mass in the trachea, right? So that's, now, most commonly, when we see something in the trachea, we assume it's
Mucus.
mucus, right? But you need to be able to differentiate between mucus and tumor. So what are some of the things that you look at to try to differentiate between mucus and tumor? So the first thing is, what's the attenuation, right? So mucus will be, what attenuation?
Fluid.
Mucus will be fluid attenuation, right? This is soft tissue attenuation, okay? So that's one thing that goes against this being mucus, right? What else?
The shape.
The shape, okay? Mucus will be very smooth, right?
Yeah.
Very smooth borders. This has an irregular shape, kind of fungating, right? So it makes you even more worried about this. What else? What are other things what are ways that help you differentiate between mucus and tumor?
Foci of air.
Air, right, air bubbles. So mucus will have, you might notice air bubbles within mucus, okay? That can help. Anything else?
Maybe it's like dependent or anti-dependent.
So mucus tends to be dependent, but sometimes you'll see it non-dependent, so that doesn't always, doesn't always work in your favor. The wall, look at the tracheal wall, okay? What do you notice here?
Coming off the wall.
Do you see the tracheal wall? No, right? You don't see it. So with mucus, the tracheal wall will be normal. With tumor, you might have thickening of the tracheal wall, or it might be obscured, okay? So I find, looking at the tracheal wall is very important if you're trying to differentiate tumor from mucus. This is, most obviously tumor, right? But there can be cases where you might be questioning it. What could this be then? So we're thinking about something here in the trachea. What could this be? What? Do carcinoids occur in the trachea? Yeah, carcinoids don't occur in the trachea. Carcinoids will occur in the bronchi, in the segmental bronchi. They will not occur in the trachea. So we don't like carcinoid for this. Squamous cell cancer, that's the most common primary neoplasm of the trachea, is squamous cell cancer. So certainly that's in a differential. What else? What are other primary tracheal neoplasms besides squamous cell cancer?
Adenoid cystic.
Adenoid cystic cancer, right? And then there's one more that's even rarer than adenoid cystic, and that's mucoepidermoid. So notice, by the way, that the cell type adenoid cystic and mucoepidermoid, those are the same cell types that also occur in the salivary glands. So it's because they result from the rests of the salivary glands. So small salivary glands in the trachea can give rise to those tumors. Okay, so the same cell type as you might see in the salivary glands. Whenever you see something like this, one other thing that you always have to think about is what lives behind the trachea.
Like an esophageal.
The esophagus, right? So esophageal cancer invading the trachea. Also, you want to think about that also. Okay, that can do something like this. Then there are rare things like hemangiomas and cartilaginous types of tumors that can also occur within the trachea. So here, how would you describe the abnormality in this case? Yeah, so there's tracheal wall thickening, right? Does it involve the posterior wall?
Yeah.
Yes, this does involve the posterior wall. Also, you have circumferential tracheal wall thickening. So a common cause of circumferential or tracheal wall thickening could be inflammation, right? So inflammatory diseases like
GPA.
Wegener's, right? You're right. GPA can do that. Do you think this is GPA or do you think this is something else?
GPA is more smooth.
Yeah, so with the inflammatory diseases, you would want something smoother. This is kind of irregular, right? So when it's irregular like that, you do need to consider neoplasm, okay? So what neoplasm can give you tracheal wall thickening like that and can extend along the tracheal wall? Which of the tracheal neoplasms does that? No. The other one, adenoid cystic, right? So adenoid cystic can have a tendency to invade submucosally. So that can give you this irregular tracheal wall thickening. It can extend submucosally along the trachea. So that can be a feature of adenoid cystic cancer, right? So these are the primary tracheal neoplasms. You also have uncommon neoplasms that can also occur within the trachea. But squamous cell is the most common. This is also associated with smoking. Can present as T fistula from invasion of the esophagus. Adenoid cystic, this can grow submucosally, right? Can grow down submucosally. By the way, this kind of abnormal growth of adenoid cystic tumors, there's a characteristic of adenoid cystic tumors of the salivary glands. Perineural invasion. So I'm trying to get you to save neurons. So you can kind of put that together, right? So that abnormal growth of adenoid cystic tumors, the same thing can happen in the trachea where it invades submucosally, okay? Mucoepidermoid, this tends to occur more along the bronchi than the trachea, but this can also occur within the trachea from salivary gland rest. So these tend to occur in the segmental airways, these mucoepidermoid tumors. Here's an example in the trachea. I mean, you would say squamous cell cancer if you saw something like this, and 98% of the time you'd be right. When you have a tumor now that's within a more distal airway, not within the trachea, now you would bring up, besides squamous cell cancer, now you would bring up what? Carcinoid, right. So this is where you would see carcinoids, and carcinoids can be associated with atelectasis. So there's an example of atelectasis here, it's carcinoid tumor with atelectasis. Okay. Metastatic tumors can also affect the airways. What are the tumors that metastasize to the airways?
Thyroid, breast. Renal.
Yeah, thyroid, breast, renal, head and neck tumors, lung cancer, and whenever the question is metastatic disease to an unusual location, a very good answer is melanoma. Right, melanoma is always a good answer for a question like that too. Okay. What about this case? What do we have here?
Papillomatosis.
So, well, what are the findings?
You got papilloma in the trachea.
Yeah, so we have these papillomas here, and in the lungs you have,
Cystic spaces.
right, so this is tracheobronchial papillomatosis. So we covered that before also. So these papillomas associated with HIV can cause papillomas in the trachea. They can also involve the lung parenchyma, and then you'll get those cystic areas in the lung. Of course, the complication of that in the lung is transformation to squamous cell cancer, right? That's the complication of papillomatosis. Okay, so papillomas can also occur within the trachea. Here's some examples here. Tracheobronchial papillomatosis. This is a 33-year-old man with stridor. What do you got here? Well, if you get the history of stridor, what are you going to look at on the chest X-ray?
Trachea.
You're going to look at the trachea very closely.
Some stenosis.
Where?
Proximal trachea.
Okay, so there's some irregularity up here. Okay, so what question are you going to ask?
Intubation history.
What?
Intubation history.
Have they been
Intubated.
intubated, right? Is there a history of prolonged intubation, right? So that's a tracheal stricture in this patient who had a history of intubation. Very easy diagnosis with CT. So with CT, you can see the irregular thickening there, the scarring, the stricture of the trachea. So that's what you see from prolonged intubation. So what happens is, usually from the balloon cuff, inflation of the balloon cuff causes pressure necrosis, fibrosis, and stricture. Usually presents weeks or months after extubation with upper airway obstructive symptoms. And then we'll see narrowing of the trachea. The stricture is very easily demonstrated on CT. This is why when you're reading the ICU films, and you notice that there's overdistension, so it's very important to look at this. Look to see if there's overdistension of the balloon cuff on an endotracheal tube. You need to tell them, right? Because that can result in tracheal injury and the complications of tracheal stricture down the road. So look for that and mention it. Tell them that it's overinflated. The balloon cuff is overinflated. And so here's examples of these strictures that can occur in the trachea. A nice volume render view of that tracheal stricture. So very easy diagnosis here with CT, and then there's a nice virtual bronchoscopy showing you the irregular thickening there where the stricture is. Okay. What do we call this? Yeah, so this is saber sheath trachea, where you see the trachea looks narrowed when you look on the AP view there, on the frontal view, but then you'll see that it's widened in dimension there, from the anterior posterior dimension there. It's narrowed in width, but it's widened in the AP dimension. What is this associated with? Yeah, so this is associated with COPD. So saber sheath trachea is associated with COPD. So it'll look narrowed there on the frontal view, but on CT you'll see that it is elongated in AP dimension. So that is saber sheath trachea. Okay. What do we have here?
Posterior membrane sphere.
The posterior membrane is spared. This is everybody's favorite.
Tracheal,
This is the
broncho,
Yeah, you-
osteo.
TBO, right. Tracheobronchopathy osteochondroplastica. So this is osteocartilaginous transformation. You get these nodules of calcification extending into the airway. Posterior wall is spared, usually inconsequential, right? Rarely it can cause problems, but usually not. So it's just that you be able to recognize it. So that's abbreviated as TBO and has this very characteristic appearance, which I think is why chest radiologists love this thing. So, and it's got the crazy name, right? TBO. I mean, if somebody just called it the tracheal osteocartilaginous nodules, it probably wouldn't be as famous as this crazy name that it has here. Okay. What's abnormal here? Oh, what do we think of the trachea? Small. What do you think of the tracheal wall? Yeah, there are some calcifications. The wall is thickened, okay? But disease also extends to the main stem bronchi, right? Is the posterior wall involved? No. So we have thickening of the trachea that extends down to involve other airways. The posterior wall is spared, kind of smooth thickening. What can do this? Yeah, so this is an example of relapsing polychondritis. So and that can also result in narrowing of the airways because the destruction of the cartilage results in that loss of compliance. So it's very easy for the airways to collapse, right? So that's relapsing polychondritis. So this also sort of recurrent inflammation of the cartilage can affect cartilage in other parts of the body. But when it affects the trachea like that, you can get thickening of the tracheal wall and you can get collapse of the trachea, and it can also extend down to the main stem bronchi. So that's relapsing polychondritis. That can give you narrowing of the trachea also. Okay. What do we have here?
Weakness,
Why?
sinusitis.
Yeah, so this is a patient with sinusitis, but they also have this thickening of the main stem bronchi, some thickening, here's some irregular nodularity there also within the trachea. So disease that affects the trachea and the sinuses, right? This is GPA or Wegener's, right? So this can affect the trachea and the sinuses. So that's Wegener's granulomatosis. So tracheal involvement can occur in these cases. It can give you diffuse wall thickening, might be smooth or irregular circumferential narrowing. Here's an example. At presentation, normal-looking trachea. 3 years later, notice the tracheal wall thickening in this patient. So you're doing CT scans on these patients with GPA. Look at the trachea. The trachea can also be involved in these cases, in these patients. So we talk about the parts of the trachea that can be involved, right? So the cartilaginous portion involves the anterior and lateral portions. So the posterior part of the trachea does not have that cartilage. So if the posterior wall is spared, you think of TBO and relapsing polychondritis. Circumferential thickening, we can see that with amyloid and GPA when you're talking about diseases that affect the trachea. Okay? So other things, sarcoid, inflammation from sarcoid can also give you airway narrowing. Tuberculosis can also do it. So these diseases can also give you narrowing of the airways. Now, what is going on in this patient? What do we see here? So when you look at the airways in this patient, what do we notice about the airways in this patient?
Overly compliant.
So what's happening to the airways as you're following this?
It's like inspiration and expiration.
So they're changing in caliber, right? So you see that as you go down, you see the trachea widens and then it collapses, and the same thing happens to the airways. So why is that happening? Because during the scan, the patient is breathing, right? And so when are the airways collapsing then?
Expiration.
They're collapsing in expiration, right? So what do we call this? What do you call the condition when this happens?
Tracheal malacia.
Tracheal malacia, and when it extends down to the bronchi like that, it's tracheal bronchomalacia, all right? So this can be associated with many things. Anything that damages the cartilage, even relapsing polychondritis can cause this, okay? This particular patient also has what?
Emphysema.
Emphysema, pretty severe emphysema. And that also is associated with tracheal malacia, right? So that's also a common association. So that's tracheal malacia. So the normal trachea on expiration, you'll get inward bowing of the posterior membrane, as you see there, okay? So on that's how you can recognize expiratory images. You get that inward bowing. It's usually less than 50% of the cross-sectional area. And this is a normal patient who's breathing during the scan. And you can see the posterior wall. See how it goes in like that, right? So that's normal in expiration. With tracheal malacia, you have here it's diffusely collapsing, right? It's not just the posterior membrane, but the whole airway is collapsing here when the patient is doing expiration. That's why if you get a request where they want to rule out tracheal malacia, right, how should you do the scan?
Expiration.
Forced expiration. So you want to do the scan while the patient is actively expiring in forced expiration, right? Because in inspiration, this could look normal, okay? If you do it at the end of expiration, again, it could possibly still look normal. You want to do it while the patient, so you have to specifically instruct the patient how to do the study that you're going to scan during forced expiration. You want to time it effectively. But the other thing now with our CT scanners is what we can do. What can you do? If you want to get the timing just right, what can you do?
Scan the whole time and then retrospectively look at it.
It's a lot of radiation. Well, how do we time boluses?
You have like bolus tracking.
The bolus tracking software is a continuous acquisition at one location. You can do the same thing here, right? So you can just bring that up and then take particular levels of the trachea, and then you tell the patient, okay, start scanning. When we say go, breathe out as fast as you can, localize the trachea, and have the patient do that while you're doing that in that one area. And then, just like I showed the posterior membrane going back and forth, you can do that also on your CT scanner. So that option is available to you, okay? So that's tracheal malacia. So from damage to the cartilage, you got abnormal compliance, and an expiration, the trachea will collapse. So there are many causes of this. Anything that damages the cartilage can give you tracheal malacia, right? So all of that is in your handout. What do we see? We'll see that abnormal narrowing of the trachea, and they'll also see the same thing when they do bronchoscopy. So you want to do dynamic expiratory CT. So when it collapses diffusely like that, that's a very typical manifestation. So here on inspiration, it'll look normal, but on forced expiration, you'll get that collapse of the trachea, and that's what you're looking for, okay? So the tracheal collapse. Now, you can have, to some extent, normal collapsibility in normal patients, so you have to be careful right? You don't want to call this on everybody, so what we look for is greater than 50% reduction in cross-sectional area on forced expiration. Even healthy volunteers can sometimes demonstrate that, greater than 50% reduction. So you want to be careful about when you call this. So ideally, the patient should be symptomatic. And what we look for is, criteria, probably better to use 70% reduction in cross-sectional area, okay, when you look for this. So it's not just a little bit, we're looking for a lot of reduction in the cross-sectional area. Ideally, the patient should also be symptomatic, right? So if you call this, you want to call this in symptomatic patients. So that's tracheomalacia or tracheobronchomalacia if it extends down to the airways. Now here's where things get really confusing. This terminology, excessive central airway collapse. This is exaggerated tracheobronchial narrowing during expiration. This can be a manifestation of tracheobronchomalacia from abnormal cartilage, right? Destruction of the cartilage that causes then the trachea to collapse. Or it might be excessive dynamic airway collapse, which just involves the anterior displacement of the posterior membrane. So it's not really the cartilage of the trachea, it's the posterior membrane that abnormally moves too far forward during expiration. All right. So the normal trachea should look like that in expiration. If you have excessive dynamic airway collapse, or EDAC, it will look like this. But tracheomalacia gives you a more diffuse abnormality where it collapses like that, okay? And this also you will see on your CT scans, right? You will see this excessive dynamic airway collapse, especially on our PE scans, because many times the patients, are not following directions and they're breathing during the scan, right? So the types of tracheomalacia, the actual abnormalities of the trachea, you can have this shape, the crescent shape, the saber sheath shape, the circumferential shape. So all of these are manifestations of tracheomalacia. But if you just have this, that is EDAC, all right? These patients aren't necessarily symptomatic. They might be, but they're not necessarily symptomatic. So if you see this, this is not necessarily tracheomalacia. This is EDAC, okay? Look for this. You will see this on your PE scans. Here we have diffuse circumferential narrowing of the trachea and the airway with some calcification. What do we think about here?
Amyloid.
Yeah, so this is amyloid. That can be associated with calcification. So what happens with amyloid, deposition of this protein because of the polypeptide chain, it's resistant to proteolysis. And so it builds up in the tissues, and it can also happen within the airways. Okay, it accumulates in extracellular tissues. Amyloid is the Greek word for starch. Congo red stain or apple green birefringence, that's what the pathologist looks for to make the diagnosis of amyloid, this deposition. Some rare manifestations, if it diffusely involves the interstitium, you can get this kind of perilymphatic nodules, this alveolar septal disease, these perilymphatic nodules. Do not say amyloid if you get a case of perilymphatic nodules, right? Unless you're asked for the fourth or fifth differential, right? You start with sarcoid or lymphangitic tumor, but start with sarcoid if you see perilymphatic nodules. But this is a rare manifestation of amyloidosis, these perilymphatic nodules. More commonly in the lungs, amyloid affects the airways, and it can give you the deposition of the amyloid in the airways, can give you circumferential narrowing of the airways. It can be diffuse or focal, so it can involve the trachea or the bronchi, as you see here. So it tends to give you circumferential narrowing. There's another example here. It can be associated with calcification, okay? Another manifestation of amyloid in the lung is as nodules. So it can give you multiple nodules in the lung. These can grow slowly. So you might have a patient who has these nodules that are growing slowly over years. It's also common for them to calcify, okay? So these nodules with calcification, we can see that with nodular parenchymal amyloidosis. So if you have multiple nodules, it looks like they're growing very slowly, can be a manifestation of amyloidosis, nodular parenchymal, and it's not uncommon for them to develop calcification. And then what about the combination of calcified nodules and cysts? Calcified nodules and cysts. What disease can give you this?
LIP pattern with Sjogren's.
Yeah, LIP with Sjogren's can give you the cystic lung disease. Is that associated with amyloidosis? Yes. So cystic lung disease with calcified nodules, this can be a manifestation of Sjogren's with LIP and amyloidosis. So this can also happen, okay? So that is our discussion of airway disease, right?